Hi, my name is Richard Ma from the University of Missouri. I'll be presenting our simple instrumentation and technique for staged ACL reconstruction. This is a typical patient case where we will consider a two-stage reconstruction where you see the tibial tunnel is markedly dilated as well as a relatively dilated femoral tunnel. What we are demonstrating here is a low anterior medial portal, making sure that this portal aligns with the pre-existing femoral graft tunnel for debridement as well as bone grafting. We'll then utilize the underwater bovie to effectively remove the graft tissue from the prior femoral graft tunnel, which is what you see on the left. We'll then utilize sharp instruments to really debride and eburnate the tunnel wall so that we could get good bony bleeding for the subsequent bone graft. The use of a 70-degree scope is particularly effective so that you can look through the lateral side and also work from the anterior medial side. In terms of the tibial tunnel, we typically prepare this in outside-in fashion. What you see on the left is just placement of the guide pin in the center position on the tibial tunnel as confirmed on fluoroscopic imaging. When then reamed in outside-in fashion using sequential reamers up to the desired size based on preoperative templating. What we'll use now is the pre-fashioned Yankauer to deliver the particulated bone graft up into the femoral tunnel, which is what you see here on the left. The bone graft is typically mixed with bone marrow aspirate concentrate that we will get from the distal femur. We then impact that into place a little bit at a time so that we can get adequate circumferential fill in terms of the femoral tunnel. This typically does not require a lot of bone graft to get a good fill. What you see here on the right is the final product where the walls of the femoral tunnel is nicely filled up to the aperture intra-articular wise. Since this is a dry arthroscopy situation, we sometimes use surgical Q-tips to dry the field of view so that we can see. At this point, we would then place the guide pin up the previously prepared tibial graft tunnel, which then allow us to load the pre-shaped allograft bone dowel that is soaked in bone marrow aspirate concentrate. This will help us guide the pre-shaped allograft that would match the diameter of the last reamer that was used to prepare the tibial tunnel. This would then guide it into place. We've also utilized particulated bone graft similar to the femur, which has also worked in the past. What you see now is the impaction of the tibial allograft bone dowel into place under direct arthroscopic visualization. We will impact this until it is seated just up to the level of the joint on intra-articular view. These are the intra-articular view of the intra-articular aperture of the femoral tunnel on the left and tibial tunnel on the right with good fill in terms of bone of both respective tunnels. In terms of the postoperative course, patient would typically be toe touch weight bearing initially with a hinge brace locked in extension until they initiate physical therapy. We would adjust the weight bearing in range of motion if there was a displaced meniscus repair that was done at the same time as the bone grafting procedure. We would then progress weight bearing as tolerated in therapy if no additional concomitant procedures were performed. Once the extensive mechanism is engaged, we would open the hinge brace for weight bearing. We would typically transition to an ACL functional brace once they transition out of the hinge knee brace until definitive stabilization of the ACL reconstruction. We would typically repeat the CT scan in about 4 to 6 months to evaluate bony incorporation of the graft tunnels. Below is the patient example with a good bone graft incorporation in both the femoral tunnel on the left as well as the tibial tunnel on the right. Thank you for watching our technique video. We hope you have found it useful, and this will assist you if you have to do a staged ACL reconstruction.